Lovely. Good afternoon, everyone. Thank you so much for your patience as we got our tech started. This is the problem when you put a social worker in charge of technology. So thank you so much for your patience. It is very much appreciated. I want to thank everybody for joining us in tonight's webinar on the safety prescribing of psychotropic medications with Dr. Mark Horowitz. The Restrictive Practices Unit and I are coming to you from the traditional lands of the Kaurna people in South Australia, and we have 850 people registered to join us from First Nations lands across Australia. There's been a huge amount of interest. I have been joking that Mark is clearly the Taylor Swift of psychotropic deprescribing. He's drawing that kind of a crowd. Tonight's webinar is being recorded, and the link in the presentation will be sent to all of the registrants after the webinar. If you require closed captioning, you can switch to it on your individual settings, which will show you what AI believes is being said. You are able to ask questions and make comments using the Q&A functions, noting that all comments are public and we won't be able to answer every question given the huge amount of interest that's been demonstrated in this topic. We will have some time for direct questions at the end of the session as well. The overuse of psychotropic medications has raised significant concerns across health sectors, mental health, aged care and disability services, and with regulatory bodies, including the NDIS Commission, the Australian Commission on Safety and Quality in Healthcare, and the Aged Care Quality and Safety Commission. The Disability Royal Commission and the Aged Care Royal Commission have both highlighted the importance of nationwide effort to reduce their overuse. Tonight's webinar is a collaborative initiative by state and territory authorisers who are working together to promote nationally consistent systems for the authorisation of restrictive practices. We are all represented here tonight, and we continue our commitment to reducing and eliminating restrictive practices, including chemical restraints, wherever possible. We know that deprescribing psychotropic medications hold many challenges, but we know that we face these challenges together, and we will do so with a strong focus on human rights, on people's safety and well-being, and on the best evidence available in terms of research and clinical practice. And on that front, it would be hard to find a greater resource than Dr. Mark Horowitz and the Maudsley Deprescribing Guidelines. Dr. Mark Horowitz is a clinical research fellow in psychiatry in the National Health Service. He's a visiting lecturer in psychopharmacology at King's College London and an honorary clinical research fellow at the University College London and a trainee psychiatrist. He has a PhD from the Institute of Psychiatry, Psychology and Neuroscience at King's College in the neurobiology of depression and antidepressant action. The man has more degrees than a thermometer. He is an associate editor of the Journal in Therapeutic Advances in Psychopharmacology. He's co-authored the Royal College's psychiatry guidance on stopping antidepressants, and his work has informed the NICE guidelines on safe tapering. He's working with the NHS to develop national guidance on safe deprescribing, and he's been commissioned by the Health Education England to develop a teaching module on how to safely deprescribe antidepressants. He is the lead author of the Maudsley Deprescribing Guidelines, which has been endorsed by the Royal College of General Practitioners as a key resource to fill this critical gap. Please get your hands on a copy of this. I am a social worker and I've been able to read it. It makes beautiful sense. There is so much great content in here, which Mark will give you an overview today. I am so thrilled to place us in Mark's very capable hands this evening. Over to you, Mark, and please let Jackie know when you'd like her to move the slides.
Okay, thank you very much, Trin, for inviting me for that warm introduction. As a balding middle-aged man, I've never been compared to Taylor Swift before, so that's it's very nice. I should say the technological problems were on my side. Trin's covering for me, so they've been very calm here with my last-minute wobble. So I'll get going here, and I'll go a little bit quicker than I would have otherwise. So I'm going to be talking. If you go to the first slides. Next slide. They move. Can you move forward? No, it's hard to. Maybe you can just use your mouse to go down to the next slide. No. Oh, okay, there we go. Yep. So go. Yep. That's working. Maybe go to the second slide. Let's see. Okay, great. So I'm going to be talking a lot about antidepressants and antipsychotics, but a lot of what I'm saying is relevant to all psychiatric drug classes. That's to mood stabilizers, to benzodiazepines, Z drugs, gabapentinoids, and stimulants. Next slide, please. The overall points that I'll be making, so you know what to expect, are that many psychiatric drugs can suppress symptoms in the short term, but may cause more harm than benefit in the long term for some patients. All psychiatric drugs cause withdrawal effects when they are reduced or stopped, and these withdrawal effects can involve mood and behavioral symptoms that can look like a return of people's mental health condition or challenging behavior. Stopping these drugs more slowly and in a way that better matches the way they affect the brain, that is, being very slow for the last few milligrams, can prevent withdrawal effects and allow people to stop the drugs safely. For example, reducing people's dose at about 10% per month, so that as the dose gets lower, the reductions get smaller, often allows people to come off long-term psychiatric drugs. And this often requires formulations of the drugs other than widely available tablets, including liquids, compounded medication, or off-label options. Next slide, please. This involves a YouTube video. I don't know if that's within our technological capacities here. You might try it, and if not, we'll move on. So while you're pressing play, either on the picture or on the link above the picture, yes, and so hopefully the volume will work as well. Let's close our eyes and wish upon a star. Sometimes you've got to.
Volume's not happening, Jack.
Okay, it may not. You sometimes have to allow it in your browser to be transmitted to Teams. But if it doesn't work, that's fine. We'll
just move on, Jack.
Yeah, let's just. I'll just briefly say what happens. So this is a montage of 3 women who had come off antidepressants. I'm sure the people in this montage are more well than most of the patients people are seeing in the audience, but they talk about, on coming off antidepressants after several years, they talk about developing suicidality, that they had never been suicidal before until they came off of antidepressants. They developed akathisia, that is this sort of restlessness and this need to pace and a sense of terror that they'd never experienced before. And for some of them, the withdrawal effects from antidepressants lasted for months or longer, and one of them took about 3 years to come off her drugs. And these are just general points that the symptoms of coming off psychiatric drugs can be very severe, to the point of people being suicidal, being very agitated. They can be worse than the conditions people were put on the drugs for, and they can last for months and years. And in all cases, these people who are from the UK were given advice by their doctors to come off the drugs in 4 weeks by halving the dose for a couple of weeks, halving it again for a couple of weeks, by taking the dose every second day, which is very common practice and is what leads to so many problems. Let's go to the next slide, please. So one of the issues in Australia and around the world, although it's been to some degree solved in the UK, is that guidelines are based on very unhelpful information. So most guidelines in Australia talking about antidepressants say that discontinuation symptoms are usually mild and last a week or 2, but can last longer in some patients. This description is based on studies produced by drug companies after patients have been on antidepressants for 8 to 12 weeks. And it's true that for most of those patients, not all of them, but for most of them, withdrawal effects are brief and mild. However, as we'll see, the longer people take medications, the more they become used to the drugs, the harder it is to stop, the more severe withdrawal effects are. And so to me, this is a little bit like an analogy to a car company crashing its car into a wall at 5 kilometers an hour and saying that the car is safe, and ignoring the fact that people are driving around at 60 or 80 kilometers an hour, so that for most people who are on long-term drugs, they will not have brief or mild symptoms. Even the phrase discontinuation symptoms is misleading because this is really an industry term for withdrawal effects, and they distributed many papers with this description, and the idea of these symptoms being brief and mild has entered kind of common knowledge. Next slide, please. Current guidance in Australia and previous guidance in the UK has suggested that to manage withdrawal effects for antidepressants, people should gradually reduce the dose, normally over a 4-week period. This guidance was actually based on a single study in which drugs were stopped abruptly, and most people had withdrawal effects. The committees at the time decided this was too quick, and they decided that stopping over 4 weeks made sense. In other words, the approach that's in the current guidance in Australia is based on no empirical evidence. It's just based on consensus from 20 years ago. We know this is the most common approach taken in practice. People will reduce the dose for 2 or 4 weeks down to half, then down to a quarter for another fortnight or month. A recent randomized controlled trial in the UK has found that most people are unable to stop their drugs with that approach, only up to 40%, and that was actually with an even slower reduction scheme. So with current guidance, most people on long-term antidepressants will be trapped on their drugs by the current guidance. Next slide, please. What this leads to is people exiting healthcare to go and find advice from online peer support forums. And the general story is, I went to my doctor, wanted to stop my drug. They told me I could stop my drug in a few weeks. The effects were so horrendous that I either ended up back on them or was unable to stop. My doctor told me that there shouldn't be withdrawal effects this severe. It must be my underlying condition. Told me I need to go back on this drug and perhaps stay on it lifelong. But I had different symptoms. I had brain zaps, this sort of sensation in my brain of it being shut off, or a little electric zap. I had dizziness. I had panic attacks for the first time in my life. So I don't trust my doctor on this topic. And I found this website more helpful than my doctor. And on these websites, they recommend coming off at 10% of your most recent dose every month. And we'll see at the end whether the advice on these websites is more helpful than the advice from national guidelines like the therapeutic guidelines or the psychiatric guidelines in Australia. Next slide, please. So this is a slightly involved slide, which I can't run my mouse over. But what I'm showing here is, if you start on the left-hand side, this is a serotonin synapse, 2 nerve cells meeting. You have little round blue circles in the first top nerve cell that have moved out into the synapse between 2 nerve cells, that then attach to the red columns on the bottom nerve cell, interact with it and send a signal down the second nerve. The blue columns are the serotonin transporter that sucks serotonin out of the synapse and ends its effects. In the second picture, when you add an antidepressant, the green triangles, they block most of the serotonin transporters. And what that leads to is an accumulation of serotonin in the synapse. So you have more red balls now. It's the equivalent of putting your foot on the accelerator. There's now more signal. And so those red receptors on the second nerve cell are getting more signal. Because of the principle of homeostasis, that is, we like to stay in the middle. When it's too hot outside, we sweat. When it's too cold outside, we shiver. These red receptors are being bombarded by signal. And what they do is they reduce in number and sensitivity. So in the third picture, you can see there's less red receptors. You can see that on neuroimaging after just a few weeks of exposure to antidepressants. Now what happens, and so that's the equivalent of the brake being put on to balance out this accelerator. Now when you come to stop the drugs, the antidepressant is metabolized from your body by your liver and kidneys in a few days or weeks, and your serotonin transporter goes back to doing its function, and the levels of serotonin go back to their normal levels. What doesn't just snap back is that brake put on the second nerve cell. These receptors don't just go back to how they were before the drug was there. In fact, we can see from neuroimaging that these changes can persist for up to 4 years after people stop antidepressants. So now what you have is a system with the brake on, and it's therefore something akin to a low serotonin system. This cartoon is a bit of a simplification. There are also other receptor targets for these drugs, and there are downstream effects. The major point is that adaptations made to the drugs during exposure don't just reverse in an instant when the drugs are stopped. And the difference between what the brain is used to and what the drug is now inputting is what causes withdrawal effects. Next slide, please. And sometimes people think that withdrawal effects can only last a few days or weeks. So doctors will say, well, that's how long it takes for the drug to leave your system. You can't have withdrawal effects that persist for longer than that. But that's a misunderstanding of what actually causes withdrawal effects. It's the difference between what the brain is used to because of these adaptations and what the drug is supplying. So actually withdrawal effects can persist for as long as it takes for these receptors to go back to their normal state, what you might think of as their factory settings, their pre-drug state. I'll give an analogy. For example, if you go to a loud concert, your eardrums will become less sensitive to sound. And when you walk out of the concert, your friends' voices will sound muffled for a few minutes afterwards. It's actually a sound withdrawal syndrome. The time taken for sound to disappear is a second when you shut the door on the concert. The reason why your friends' voices sound muffled is because it takes a couple of minutes for your eardrum to relax. The same thing is true of psychiatric drugs. It can take months or years for people's brains to go back to their normal state after the drugs are stopped, and that's why we know withdrawal effects can last for so long. We see this in animals. Animals exposed to antidepressants or antipsychotics show changes in their systems for months or years after stopping. Next slide, please. So a psychiatric drug withdrawal syndrome are physiological symptoms that occur on stopping or reducing the dose of an antidepressant or other psychiatric drug. They manifest in either psychological or physical symptoms because these drugs affect so many bodily systems. They occur because changes or adaptation to the brain by the drug take time to resolve. Withdrawal symptoms do not require addiction. This is another common misunderstanding. You only require adaptation to the drug. So for example, antidepressants, antipsychotics, and benzodiazepines taken as prescribed, most people are not abusing these drugs, can cause adaptation of the brain to these drugs to counteract their effects. This is often called physical dependence in pharmacology literature, which has become unfortunately conflated with addiction, although they're separate issues. So you don't need to have craving, compulsion, abuse in order to have withdrawal effects. As an example, I would guess that most of the audience is physically dependent on caffeine. Nobody is injecting it, stealing from their neighbors to get more caffeine. But if you were to stop it, you would get a withdrawal syndrome, not a particularly severe one, because you are physically dependent on the drugs. And the same is true for psychiatric drugs that are used for more than a few days or weeks. And the greater the degree of adaptation to the drugs, so for example, higher doses, longer use, the greater the withdrawal effects. And the flip side of this is tolerance to the drug. So often people say that tolerance doesn't occur to psychiatric drugs, but it does to all psychiatric drugs because it's impossible to have withdrawal effects without tolerance. In America, our colourful colleagues call this poop out. Next slide, please. There are a long list of withdrawal effects from antidepressants, and this is just a selection because they affect so many different parts of the body. They can cause dizziness, insomnia, impaired concentration, fatigue, headache, tremor, tachycardia, nightmares. There are mood symptoms like depressed mood, irritability, anxiety, panic attacks, agitation. We know that these are withdrawal effects and not just a return of people's underlying condition because they are found even in people without mental health conditions. So for example, in studies of people that were given antidepressants for the menopause, for pain, and even in healthy volunteers, when they stop, they can experience these symptoms. There are also some distinctive sensory symptoms. I've mentioned electric shocks, particularly eye grabbing. There are gut symptoms because these drugs affect the gut. There are lots of serotonin receptors in the gut. There's an increase in suicide attempts in the 2 weeks after stopping an antidepressant, which has been attributed to withdrawal effects and not to relapse because it's too soon for relapse to be relevant. I'll show you in a couple of slides. We did a study where we asked people before you started antidepressants, were you suicidal? And 3 out of 10 said that they were. Were you suicidal after stopping antidepressants? To that 6 out of 10 said that they were. So that for 30% of people in this study, they experienced new onset suicidality after stopping antidepressants that was not there beforehand. Akathisia was in the video I was going to show. This is recognized as a long-term side effect of antipsychotics, but it can also occur as a withdrawal effect from all psychiatric drug classes. These are the sickest patients that I see. They are often pacing, they express a sense of terror, they describe themselves as feeling like their nervous system is on fire, and they're often at high risk of suicide. And these presentations are often misdiagnosed as agitated depression, bipolar, or psychosis when clinicians are not familiar with the fact that these drugs can cause akathisia and withdrawal. Next slide, please. There have been a few reviews recently on how common withdrawal effects are. Some of them find half of people experience withdrawal effects and a quarter experience severe withdrawal effects. More recent reviews have found that shorter duration of use leads to less severe symptoms. I think the most interesting relationship is the duration of use and withdrawal effects as shown in this graph. So the longer people take antidepressants, and this is true for all psychiatric drugs, the more likely they are to have withdrawal effects, that's the top line, and the more likely those symptoms are to be severe or moderately severe, that's the line beneath it. So if you're on the drugs for a few weeks or a few months, most people don't have withdrawal effects, and most of those effects are mild, and that's where the drug companies conducted their studies to show that there were mild and rare symptoms. But once people are on these drugs for more than a few years, most people are having withdrawal effects, and half of them are saying that they're moderately severe or severe. Next slide, please. Another issue is misdiagnosis of withdrawal effects as a return of people's underlying condition or relapse. We surveyed 1,000 people, and they said this is the reason why they had left healthcare to go to these online websites. It makes sense why this would occur. Withdrawal effects include anxiety, depressed mood, insomnia, etc. And when clinicians have been educated that these withdrawal effects are mild and brief, when someone walks into your office or you see them in the emergency department or in a clinical facility and they have severe symptoms, it's easy to jump to the conclusion that they must have had a relapse of their underlying condition or onset of a new physical or mental health condition. Next slide, please. There are a few ways to distinguish withdrawal from relapse. Number one, withdrawal tends to be quicker in onset, can occur a few hours or days after stopping. We also know that it can be delayed in onset, which can be confusing. It can take a few weeks. We think this is because it can take longer for the drug to leave the brain than we have established from their peripheral half-lives. And there are also probably downstream effects that can take a while to manifest. There are specific symptoms that can make it clearer that this is withdrawal. Things like dizziness, electric shocks make it much clearer that it's a withdrawal syndrome than a return of underlying condition. However, psychological symptoms are the most common withdrawal effects from these drugs. And so extreme symptoms or new symptoms should be a sign that this could be withdrawal. For example, if someone went on the drugs a few years ago because they were very low in mood, they were lethargic and sleeping all the time, and now they've come off the drugs and they've developed panic attacks and anxiety, it's much more likely that they've developed quite common withdrawal effects rather than coincidentally developed a new onset panic disorder that just happens to coincide with the moment they stopped their drugs. There are all sorts of misdiagnoses that occur, things like chronic fatigue syndrome, medically unexplained symptoms, neurological disorders, onset of a new psychiatric disorder that occur when people are unfamiliar with withdrawal effects. What's often more useful in retrospect is if you reinstate the drug, symptoms will often go away quickly if it's done soon after people come off their medication. Next slide, please. Protracted withdrawal syndromes, I think, are not well appreciated. There's more recognition of short-term effects, but people still are not recognizing these long-term, months or even more than a year-long withdrawal syndromes. This is the study I was referring to. We asked people, did you have symptoms before starting antidepressants on the left column, and did you have them after stopping? And you can see that lots of symptoms were present before starting the drugs. These people were depressed, they had various physical symptoms, but after stopping, all of these symptoms increased to a greater degree than they had them before starting the drugs. In other words, a lot of these symptoms are because of stopping the drugs, not shown here, but they're also much more severe. So things like suicidality, akathisia, panic, dizziness, all were increased in intensity and were much more common in stopping. These symptoms can persist for months or years. They can occur for many different psychiatric drugs, coming off benzodiazepines, antipsychotics, or antidepressants. People can end up being bedbound. They have trouble with light, with panic attacks, with concentration, all sorts of symptoms. To me, it looks a lot like long COVID, but to me, it looks more severe. There was better recognition of long COVID because it occurred to so many people at the same time, and also because medical staff were affected. Protracted withdrawal syndromes are much less recognized, and it leaves people to fend for themselves because the medical system doesn't recognize things. And so now there are tens of thousands of people who are relying on friends and family to get through this because doctors don't recognize this condition. Next slide, please. Why stop antidepressants and other psychiatric drugs? I'll just whiz through this. There are lots of reasons why medication may no longer be needed. Most people are prescribed these drugs in the context of a stressor. Most people don't have severe recurrent disorders that are prescribed antidepressants in particular. That might be less true for other drug classes. Most people are on these drugs for longer than guidelines recommend. I know people are dealing with challenging behavior that may have settled. There are a huge number of side effects from these drugs, all the way from weight gain to sexual side effects to emotional numbing to, in some cases, worsening mental state. Next slide, please. And next slide, please. Skip through this one. There's another issue out there. I think we've got some questions before this lecture, which is why would you stop a drug if it's helped people? I think this is where we need to think a little bit about what causes depression and other mental health conditions. So for years, the public and clinicians have been told that antidepressants work by rectifying an underlying chemical imbalance, normally said to be low serotonin. Often patients are told that antidepressants for depression is like insulin for diabetes. Now, the idea that depression was caused by low serotonin was initially a scientific hypothesis, which was generated in the 1960s. It was amplified by the manufacturers of antidepressants. And there have been various studies. We did one a couple of years ago looking at the evidence for low serotonin in depression. And essentially what we found is no major difference. If you go to the next slide, please. We looked at all the existing research comparing serotonin levels in body fluids, in cerebrospinal fluids, looking at serotonin receptors, transport protein, genes, tryptophan depletion studies. And next slide, please. Essentially what we found is no evidence depression is associated with lower serotonin concentration or activity. There's no difference between healthy volunteers and depressed patients. There was a few studies suggesting actually there may be increased serotonin in some patients, but that's probably due to the effect of drugs. Go to the next slide. We're not alone in this conclusion. Most colleges of psychiatry around the world now say that this is no longer a tenable explanation for what causes depression. So the Royal College of Psychiatrists said the old idea that antidepressants work by correcting a chemical imbalance is an oversimplification. We do not support this view. They've removed this kind of language from their leaflets. The same is true in America. They've said that this hypothesis has not been supported, and some psychiatrists said that they had never put forward that idea, or no well-informed psychiatrists had done so. So what do antidepressants do? Next slide, please. This is a bit more of a general issue about how do psychiatric drugs work. And there's two ways of thinking about how psychiatric drugs work, which I think is a useful frame. One is called the disease-centered model. And this is the way that drugs are thought to work in general medicine. So for example, that drugs work on an underlying abnormality. So for example, if you've got a chest infection, you take an antibiotic, it kills the bugs, and the cough and the fever disappear, and people feel better, or that insulin replaces a lack of it in diabetes. In the mental health world, people often say that drugs work in a similar way. And this is, for example, that antidepressants will correct a serotonin deficiency. Next slide, please. But this is not supported by research that there's low serotonin. In fact, I haven't gone through it all here, but there are various meta-analyses looking at abnormalities in people's brains in depression, and they find that there's no differences in inflammation, in stress hormones, or in any structural abnormalities. So there's yet to be found a definitive difference between the brains of healthy volunteers and depressed people. There's also a lack of evidence that any drugs have a specific effect. So for example, in studies giving people antipsychotics, stimulants, benzodiazepines, antidepressants, all have the same small antidepressant effect. There's little evidence of any specificity. Next slide, please. So another way of thinking about the way that psychiatric drugs work has been called the drug-centered model. And in this frame, psychiatric drugs are seen to be psychoactive drugs that cross the blood-brain barrier and affect the way that we think and feel, that is not that dissimilar from recreational drugs that also have effects on the way we think and feel. Often drugs like cocaine and alcohol are experienced as pleasurable, whereas drugs like mood stabilizers and antipsychotics are not experienced as pleasurable, but they do change the way we think and feel. Next slide, please. And the effect of the drug, whether it's sedation or relaxation, for example, for benzodiazepines, may be experienced as relief for someone who is agitated or anxious. However, this is not the same as returning somebody to their normal state or their pre-symptom state. In other words, these drug-induced changes to thinking and feeling are superimposed on people's existing conditions. So, for example, alcohol is a good analogy. If someone is socially anxious and they drink alcohol, they will feel less anxious and less inhibited in social situations. Nobody thinks that social anxiety is caused by an alcohol deficiency or that alcohol fixes a biochemical abnormality. Everybody understands that the drugs are superimposing effects on top of people's underlying condition that will dissipate when you stop the drug. Next slide, please. And that is one way of looking at psychiatric drugs. So, for example, antidepressants are notorious for causing emotional numbing, and you can see how someone having their emotions numbed may make people feel relief in the short term from anxiety or panic, but is not the same as correcting an underlying biochemical abnormality. And when you think about drugs in this way, it makes sense why there would be tolerance, like I suggested before. There'd be withdrawal effects as the brain gets used to the drugs when the drugs are stopped. And while the drugs may be useful in certain circumstances, they can also have harms in the long term. And it is quite possible for drugs to do more harm than good, especially in the long term, although they can be helpful in the short term. Next slide, please. So just to summarize this, one way of thinking about drugs is the disease-centered model. Drugs correct an abnormal brain state. The therapeutic effects arise from reversing the underlying biological cause of a condition. An example would be antibiotics in an infection or insulin in diabetes. And in the drug-centered model, drugs create an abnormal brain state. Their useful effects are because they superimpose effects on top of underlying conditions or symptoms. And an example would be alcohol for social anxiety. And that is one way of thinking about the way that psychiatric drugs work. Next slide, please. We know that many people believe that they have a chemical imbalance in different conditions because they've been told that. We know that people that believe that are much less likely to stop drugs even when they're no longer indicated. That's an important barrier. There are health consequences for antidepressants and also for antipsychotics, which we'll talk about it in a bit. In long-term studies, people who are taking antidepressants have a higher risk of strokes, obesity, falls, cardiovascular disease, osteoporosis, and premature mortality. And there's debate about the degree to which that is caused by underlying conditions or the drugs themselves, which at least some of that causality attributed to the drugs. There are specific issues for young women wishing to become pregnant. Next slide, please. So I'm going to talk now about how to avoid withdrawal effects, what's the best way to stop these drugs. And I'm going to be referring to start with to the Royal College of Psychiatrists in the UK, their guidance on how to stop antidepressants. But a lot of what I'm saying here applies to all psychiatric drugs. So this was published a few years ago, and it recommends that antidepressants are stopped over months or years, that they should go down to very low doses, less than 1 milligram for many drugs, for some people, and that you should go down in smaller and smaller size reductions, and that the rate should be adjusted to the individual's ability to tolerate the process. So some of that might sound quite unfamiliar. I'll explain where it came from. Next slide, please. This is a study we published a few years ago in the Lancet Psychiatry, looking at the way that antidepressants affect the brain. So this is a neuroimaging study showing dose of citalopram on the x-axis and essentially effect on the brain. It happens to be serotonin transporter inhibition. The main point of this graph is it's not a straight line. A dose of 40 milligrams doesn't have twice the effect of 20 milligrams on the y-axis. There's only a small difference. And actually, if you go down to 2 milligrams of the drug, which people would laugh at as a homeopathic dose, actually has about half the effect of 60 milligrams. And the reason why this relationship arises is because of something called the law of mass action. When there's not much drug in the system, all the receptors for the drug are open for business, they're unsaturated, and so every extra milligram of drug at low doses has a large effect. And then as there's less and less receptors available to be interacted with, every extra milligram of drug has less and less effect. This is a bit like the game of musical chairs, where it's easy to find a chair at the beginning and harder at the end. And this gives you the sort of law of diminishing returns. Next slide, please. And that allows us to understand what happens when people reduce their drugs in a way that most doctors recommend, which is to halve the dose, say from 20 to 10, then to halve it again from 10 to 5. Going down from 20 to 10, if you look at the y-axis, it causes a reduction in effect, which people can find quite unpleasant. 10 to 5 is a bigger reduction again, which people can find even more unpleasant. And going from 5 milligrams to 0 milligrams is a bit like jumping off a cliff. It has about 20 times the effect of going from 20 to 15. In other words, a much larger effect for those last few milligrams. And this is exactly what patients describe. The first few milligrams of a drug are the easiest to reduce, and after that, it gets much harder. Next slide, please. So what makes more sense is not reducing by even amounts of dose, but reducing by even amounts of effect on the brain. So I've drawn 4 horizontal lines here to reduce the drug by even amounts of effect on the brain. And that corresponds to smaller and smaller size reductions of dose, which go all the way down to this tiny dose of 0.8 milligrams. And that's so that that reduction from that dose to 0 doesn't cause a larger change in effect on the brain as those previous reductions. And because this curve is called a hyperbola, this kind of tapering has been called hyperbolic tapering, and you can see how small the final doses are before stopping. Next slide, please. An approximation of this kind of tapering is to reduce by a percentage of your most recent dose. So for example, reducing by 50% of your most recent dose every month would involve going down from 20 to 10 to 5, 2.5, all the way to 0.6. This causes roughly equal changes in effect on the brain. Some people find even that rate too quick. Some people will go down at 25% per month of their dose, and others find that going down at 10% of their most recent dose per month is as fast as they can tolerate. And so you can see that people on those peer support websites I mentioned at the beginning of the talk have actually worked out through trial and error a relationship that corresponds exactly to what is found on neuroimaging of these drugs. So I think that's no coincidence. What I've said for citalopram, on the next slide, please, is actually true for all psychiatric drugs. It's true for fluoxetine, it's true for sertraline, it's true for paroxetine, it's true for venlafaxine. I put a red line as to where the smallest tablet or capsule in Australia is. And you can see for all of these drugs that the smallest tablet or capsule, though it seems like a small dose in terms of the smallest tablet, actually is a large dose in terms of effect on the brain. And when people try to stop from that dose or even half that dose, they're being thrown off this cliff. And that's why people get into so much trouble coming off antidepressants and other psychiatric drugs when they come off. Very briefly, the next slide, please. There have been a few studies now looking at can this sort of tapering, this hyperbolic tapering going down by smaller and smaller amounts over a longer period of time help people come off their drugs. There have been a few studies done in Holland. In this one, there was 900 patients who were mostly unable to stop their drugs using a linear taper. That's the usual halving and halving again. They were given access to small dose tablets that allowed them to have a hyperbolic dose reduction. In the middle picture, you can see they went down quickly to start with and then slower and slower. And most of these people were able to come off the drugs in this way. And when they were asked, what was it like coming off the drugs in the traditional way? They mostly said the symptoms were very severe, 7 out of 7 on a Likert scale. And they were asked, what was it like with the slower hyperbolic taper? They said it was mostly 2 out of 7, much more mild. Next slide, please. The Royal College guidance says that we should adjust the rate to what can be tolerated by the patient. There are some risk factors that I'll go through in a minute, but it's very hard to guess exactly how someone will respond. So there has to be adjustments. If people get into trouble, the rate should be halted or the dose increased and then made more slow after that. And the Royal College now recommends that some people can only come off at 10% per month. Next slide, please. This is an example of what I would call a fairly rapid reduction of citalopram, maybe for someone who's been on the drug for a year or two, not long term, going all the way down to 0.6 milligrams using a liquid. And next slide, please. For a drug like paroxetine, it's particularly hard to come off. People can take 2 or 3 years to do that, reducing at about 10% of their dose every fortnight or month. So that there are many, many steps in this sort of reduction. Next slide, please. The question I'm always asked now is, how do you make up these small doses? And the answer is, it's difficult in Australia because liquids are the easiest way to do this, but they only are made by the manufacturer for escitalopram. For other drugs, you can get compounded medications. People can compound liquids or capsules or tablets. Some people try to skip doses to help patients come off. That's often not very wise for most drugs, because most antidepressants and many other psychiatric drugs have a half-life of 24 hours or less. And so dosing every second or third day causes wildly changing levels in the blood, which can cause withdrawal effects. Others think that fluoxetine has been advertised as self-tapering, that you can just stop it. That's not true. About half of people stopping fluoxetine will have withdrawal effects. It's just often delayed because it has a long half-life. So fluoxetine is not a free ride. Next slide, please. There are also off-label options for making smaller doses. So this is a website from the NHS in the UK, which explains to people who can't swallow tablets how to crush up and mix with water antidepressants in order to swallow them. There's also other guidance in the UK for mothers and fathers to make small doses for children. So it's perfectly reasonable to crush up tablets and mix them with water to make up small doses. Next slide, please. As Trin already mentioned, we wrote this textbook as an outline for GPs, for pharmacists, and for nurses on how to safely stop antidepressants, benzodiazepines, gabapentinoids, and Z drugs. We talk about working out who's at high risk of withdrawal, how to plan a taper for somebody, how to adjust it, and which formulations of drugs to use in Australia. Next slide, please. Here's an example of stratifying risk for antidepressant withdrawal, for example, based on how long people have been on the drugs, short-term use, much lower risk. Which type of antidepressant? Certain ones have a higher risk, like SNRIs or paroxetine. Dosage has a small effect, and people's past experience also can affect their risk in the future. Using this sort of scoring, you can work out who's at high and who's at low risk, and based on that, work out what's a good starting taper. Next slide, please. We give examples of reduction regimes, when to use tablets or half tablets, when to use liquids. Next slide, please. And also when to do something slower for people that have trouble. Next slide, please. I think I'll skip through this. People can also open up capsules to count beads, is a way that people do it. It's been checked by the manufacturer that these beads, their pharmacokinetic properties are intact when they are exposed to air. So it's a perfectly reasonable way to reduce these drugs. It's often what patients resort to. Sometimes clinicians say this is too much trouble, but I would argue that it's much more trouble to push someone off a drug to give them a severe withdrawal syndrome than it is to teach somebody how to count beads. Of course, this relies on people having the wherewithal to be able to do this. For other people, you can use liquid versions of drugs made by a compounding pharmacy. Next slide, please. There are drugs that are dispersible in water. Some drugs can't be crushed up, like duloxetine. And I mentioned that Lexapro is available, or escitalopram is available as a liquid in Australia, which can make things much easier. Next slide, please. I'll just talk briefly about antipsychotics. Next slide, please. There's lots of reasons to stop antipsychotics. There are a whole host of adverse effects, from movement disorders to metabolic problems to probable brain shrinkage over time. They can affect people's long-term functioning, and they can be very unpleasant subjectively. Next slide, please. Antipsychotics also cause withdrawal effects. I'll skip through this. Go to the next 3 slides, please. 1, 2, 3. Yeah, stop there. Again, it depends on the targets of the drug, but again, half of people stopping antipsychotics will have withdrawal effects. This can involve insomnia, movement disorders, anxiety, psychotic symptoms, agitation. Certain drugs are worse than others. Next slide, please. This is the same sort of issue I showed you with antidepressants. Essentially, when you give people an antipsychotic, it blocks dopamine signaling. It's like putting the brake on. Next slide, please. The brain adapts by pressing down the accelerator this time and leads to more receptors being formed on the right-hand picture. Next slide, please. And now when you stop the drug, you have the accelerator on with the brake taken off. And that's why people can be very agitated or psychotic or otherwise dysregulated, because they now have an excess of dopaminergic activity. Next slide, please. I've mentioned some of these symptoms already. Next slide, please. I'll just explain this briefly. People, even without psychotic conditions, can experience extreme agitation and even psychotic symptoms on stopping. So, for example, women who are given dopamine blocking drugs like domperidone for issues with lactation, who when they stop the drugs can develop psychotic symptoms. So even though they have no underlying mental health issues, it can cause psychotic conditions. And so the same is true with people with dementia or even with people with psychotic conditions. If the drugs are stopped quickly, it can lead to these severe withdrawal effects. Next slide, please. That is also evidenced by the fact that the slower the drugs are stopped in studies, the less relapse people recognize in schizophrenia. In other words, what this is saying is the slower the drugs are stopped, the less disruption is being caused to people. That probably means there's less withdrawal effects being misclassified as relapse. In other words, stopping drugs more slowly can cause people to have a lot less trouble. Next slide, please. This should all look familiar now. Everything I said about antidepressants is also true for antipsychotics. So you can see the same hyperbolic relationships. You've got dose of haloperidol, dose of risperidone. The same is true for quetiapine, where the dose has a hyperbolic pattern of effect on its target receptors, so that small doses have much larger effects than you would expect. The right-hand diagram shows that this is not just some relationship in brain imaging. This is about symptoms. So even low doses can have a bigger effect on symptoms than you would expect. So the same pattern of relationship. Next slide, please. And the same therefore applies to tapering these drugs. So some people think that stopping haloperidol or quetiapine or risperidone, you can do it in this linear way, go from 4 to 3 to 2 to 1. But in the same way as for antidepressants, this will have a larger and larger effect on the brain. So for example, for this drug, 0.25 milligrams, which is a quarter of the smallest tablet, actually has a larger effect on the brain than going from 10 to 2 milligrams. Next slide, please. And so it makes sense to taper antipsychotics also in this hyperbolic pattern, going down by smaller and smaller amounts down to tiny final doses, often using liquids to avoid this being pushed off a cliff scenario. Next slide, please. You can see an overview of a way of tapering different antipsychotics, including quetiapine, which I know is often used in nursing homes or for behavioral control, down to very tiny doses, often smaller than the smallest available tablet. And some people need to go even slower than these regimens suggest. Next slide, please. Essentially, the tapering rate should be similar to what I've outlined for antidepressants. It can take months or years after long-term use. For shorter-term users, it can be quicker, but going down at, say, 5 to 10% per month of your most recent dose is what long-term users can tolerate. Next slide, please. And again, everything I've said for antidepressants is true for lots of other drugs. So NICE now says that for opioids, for benzodiazepines, for Z drugs, the same approach, reducing by a proportion of the most recent dose, so that reductions become smaller and smaller as the dose is lowered. And that is because, next slide, please, the same relationship exists for all psychiatric drugs and their effect on their target receptors. So here is diazepam or Valium, and its effect on GABA receptors. You can see that in the table on the right-hand side, that going from 1 milligram of diazepam to 0 milligrams actually has a larger effect than going from 100 to 75. In other words, the last few milligrams have an outsized effect. on the brain. And next slide, please. And here are some examples of tapering schedules from the Maudsley textbook. On the left-hand side, a faster taper off diazepam. You can see you can take people several months or more than a year, and a slower taper for people with difficulty on the right-hand side, using tablets and then eventually using liquid versions of the drugs or hard tablets. And next slide, please. Pregabalin and gabapentin are being used more and more. They were presented to clinicians as not having the same issues as benzodiazepines, but they of course they do. They cause tolerance, they cause dependence, they cause addiction. There is issues in the UK with increasing deaths due to gabapentinoids, where there's a mini opioid crisis with gabapentinoids, a lot of unintentional overdoses, and they're being regulated more and more closely here. They're used widely off-label, gabapentin and pregabalin both, and the same issues apply to them, that small doses have much larger effects than you would expect, as you can see from the same now familiar graphs of pregabalin and gabapentin here. And again, it makes more sense to go down by smaller and smaller amounts with these drugs at lower doses. And next slide, please. I haven't covered every drug around, but everything that I've said, the drugs cause dependence, the brain adapts to them. When they're reduced or stopped, they cause withdrawal effects. Those withdrawal effects can cause people to become agitated or depressed or anxious, or cause a wide variety of other symptoms that can be mistaken for a return of people's underlying condition or evidence that they need the drugs, and that all of these drugs, smaller doses, have bigger effects than you would expect, and it makes sense to go down more gradually for lower doses, and that for many of these drugs, it's better to use liquids or other versions of ways to make up small doses to get people off at the end. And next slide, please. So happy to take, there's some time for questions. Sorry for talking so fast. And I'll point out that the textbook is available free to GPs through the Royal College of General Practice, and I hope that Trin might send around a link to the GPs at least to redeem that. Thanks for listening.
Great. Thank you so much, Mark. I think people, we're certainly seeing lots of comments and lots of questions that have been raised, and people are very much hearing this incredibly complex but also incredibly useful content. We'll get Jackie to stop sharing her screen and we'll flick to some questions. If I can start perhaps by capturing, as much of a snapshot as I can, the key takeaways that I was hearing through this presentation, which is that the traditional approaches to deprescribing appear to be underestimating the length of time that is required to deprescribe and underestimate the duration and frequency of withdrawal symptoms. And the research is actually indicating that it may take months and years to come off psychotropics, especially for somebody who's been on them for extended period of time, and often years. The withdrawal symptoms may be prolonged and severe, particularly at those last dosages of reduction, and reduction really needs to be based on people's level of tolerance, and if they're showing signs that they're not tolerating, to pause, allow the symptoms to settle with support, and then to continue to deprescribe. Is that a reasonable snapshot of what the Maudsley Deprescribing Guidelines are telling us?
Yes, yeah. Full marks, exactly. So the guidelines existing are too quick, leads to lots of trouble. People often misdiagnose those troubles as a return of people's underlying condition, and going a lot more slowly can avoid those problems. Exactly. Yeah.
Absolutely, and we've certainly had feedback from the sector, and certainly in the comments as well, that people are really keen to have this information. They're really wanting this information to be shared with GPs and prescribing doctors, which is why we have actually shared this link across Australia, and we do have many GPs and prescribing doctors who have been involved here. And as you said, with your support and the Royal College for GPs, the Wilson Foundation will be sending out that additional link to the GPs and prescribing doctors so they can get a free e-version of the guidelines, which I think will be so important. We've got a couple of questions that have been asked. The audience that have joined us today come from the disability sector, so working with people with learning difficulties and cognitive impairments. They're coming from the aged care sector, the mental health sector. From the research, are there notable differences in deprescribing considerations or processes for children versus the aged versus people with disability versus male or females, or any cultural differences?
Right. So I should say, so for hearing that people are coming from the disability sector or from old age, there are specific guidelines in the UK about who should have their drugs stopped. There are these stop and stomp criteria for different groups. The question is, do people have differences? There hasn't been huge amounts of research comparing children to older people, etc. There's been a few studies finding relationships one way or the other. I think I hope that children will have an easier time because they've often been on these drugs for a shorter period of time. Some studies find that women have a harder time. Some studies find that men have a harder time. I would say, though, that the overarching approach is the same for whatever group you're looking at. It's better to do things slowly and see how people react and use that to guide how quickly you'll go. So a test reduction of 10% of someone's dose, see how they respond to it, and based on that, make the next reductions. Because there's not really enough research to say, well, this person should go at this rate for 6 months and this one should go for 18 months. So I'll be very adaptive and following what the person, how they experience the process.
And Mark, we've got a great question here from Joe Cooley about the reduction for where the patient may be experiencing polypharmacy. They may be on multiple psychotropics. How does a care team and a prescribing doctor work out which one to start first?
So I had a quick slide on this, but I'll just read it out because it's a bit complicated. So, I mean, the answer is there's no great evidence on one way or the other. My advice is start somewhere. There's two approaches. One is to take the drug that you think will be easiest to stop to give both the patient and the care team confidence. So maybe that's the drug that has been started most recently, or it might be a drug like a Z drug that's fairly easy to stop compared to longer term drugs, or it may be the drug that causes people the most trouble. So the drug that has the least amount of benefit for the harm. In general, what I do with polypharmacy is start with one drug. When people get the hang of that, I might bring in a second drug because it's very hard to start two drugs at the same time. If people get into trouble, it's very hard to know which one has caused it. Some people will put off stopping drugs that, for example, affect sleep with the idea that the process of withdrawal might be disruptive to sleep. And so using a drug that's helpful may protect people. But I think the main thing is to start somewhere in a small way and use that to make the next reductions.
Mark, we certainly talked in the sector, both the aged care sector and also the disability sector, about doctors really being reliant on the patient to be able to describe their symptoms and describe their experiences. But where somebody might have a disability or a cognitive impairment, which either means they might not be verbal or they may not be able to differentiate between past and current symptoms, what kind of signs or behaviours or symptomologies should third parties be looking for to be reporting to the GP or the prescribing doctor so they can make a really well-informed decision?
Right. So very fair question. So I've talked a lot about on this process being reliant on people giving feedback, how they're feeling. How does that people that don't have those verbal skills? It does make it harder. I've talked to clinicians who are taking people off these drugs with learning disabilities, and they use behavioural cues. There are ways of knowing if people are more less agitated to be able to work out what rate works for them. In older people, a similar approach, using a kind of behavioural readout. But I would say, broader point, this brings up two major issues. one, I've talked a lot about stopping the drugs, but this is a reason to avoid starting drugs in the first place that are unnecessary, because it can be very complicated. I think one of the main points I'm trying to make is it can be very involved and very complicated to stop the drugs. Most people don't realize that, and that should be priced into decisions about starting the drugs. They should only be used if they're absolutely necessary. And for older people, at least, there's a lot more disadvantage to being on the drugs as an older person. Your liver and kidneys can't clear the drugs as well. But it's harder to stop the drugs when you're, more fragile. And it's a good reason, therefore, to stop the drugs earlier. So, people are thinking about older adults not using these drugs, but it would be better to stop them in middle-aged adults who are well enough to do that. So I think this is, using behavioural outputs to guide reductions, but also thinking earlier on about when to stop the drugs so that people don't end up in this position when they're older, where they're unable to come off because it's too complicated.
And Mark, I was just reflecting, and this is not a question, but perhaps a reflection, which is when you're talking about people going on the drugs in the first place, being able to be really, really clear about what are the reasons why the person is going on the drug and how we believe it would benefit them, and having clarity about what the drugs are actually doing, what the medications are actually doing, but also then having that information available in the person's patient history, so that when later on they are taken off the medication, you can actually have a point of comparison around, is this the same behavior that got them onto the medication in the first place, or are we seeing a very different set of behaviors? Is that a fair comment?
Yeah, that's a really good point, Trin. So one of the ways we do that all the time in the clinic, I run a deprescribing clinic in London. We're very careful at looking at what were the symptoms that put people on the drugs, because it makes it easier to work out what is new, what is withdrawal, what happens when they're off the drug. So that's a very useful thing, and that would be made a lot easier by putting in the notes, why the reason people go on the drugs in the first place. So that's a great point.
So, I mean, Mark, you've just talked about your deprescribing clinic in London. We're feeling very envious. I'm sure everybody in the group here is feeling very envious of the clinic. And you're also working to develop further guidelines on deprescribing. What developments are you aware of in Australia to support safe deprescribing along those same lines?
It's been pretty mixed, let's say. So, there's been, I guess, the UK and Australia have sort of diverged. They have very similar health systems. I know there's competition between the UK and Australia when it comes to cricket, but I think there should be more competition when it comes to updating guidelines and best practice, because in the UK, the guidelines have been updated to reflect a lot of what I've shown here, that people should stop the drugs more carefully, that people should use liquids if needed, that withdrawal effects can be very severe and long-lasting. In Australia, places like the Therapeutic Guidelines, the Royal College of Psychiatrists guidelines on stopping antidepressants and other drugs still say the kind of old-fashioned stop in a few weeks, there's not many troubles. I think that's very misleading to clinicians. I don't blame clinicians, because the guidelines they're following the guidelines actually correctly. It's that the guidelines are out of date and not based on the latest. The Royal College of General Practice seems to have made some moves because they've endorsed the textbook that we wrote, but they don't write guidelines themselves. They don't seem to have made a move recently to put out more continuing education for GPs on how to do this. I hope that's something they might consider. Psychiatrists haven't updated their guidance, and this is not a core part of the curriculum. So I think it's what's happened is the occasional psychiatrist or GP has taken this up of themselves. Some of them have bought my book or corresponded with me, but I think in general it's been very slow. It hasn't been taken up by the colleges to educate their members, and so I think unfortunately Australia is lagging behind in this area, and there needs to be a lot more work to upskill clinicians, maybe to make liquids available to clinicians as well, because, for example, in the UK, most psychiatric drugs are available as liquids, and the reason for that is because they were asked for by clinicians and by colleges and by patients. And so probably the same thing needs to happen in Australia, so that these options are easier and more feasible for patients and clinicians.
And I can see, Mark, that's exactly what our attendees have been commenting in the chat about some of those systemic barriers for people who are really wanting to do the right thing, who are really wanting to support safety prescribing, but are coming up against those systemic barriers around the awareness in the sector more broadly about safety prescribing, but also the availability of medications at those very low dosages. I think there was some commentary that compounding pharmacists are available, but the cost of the medications can be prohibitive in some circumstances as well. So we can see that there are some clear barriers, but from what you're indicating, the UK has gone through the same process, and because of greater awareness, has been shifting to making more of these medications available in a form that does support deprescribing to those lower dosages.
Yes, exactly. So I'd say a couple of things about that, because that's a major issue. I sort of know when I give these lectures in Australia, I'm giving people a headache, because I'm suggesting to do something that's much more complicated, that's not easy to do with sort of off the shelf formulation. I still think it's important for people to be aware of this so that people can ask. I would say that what we're deciding now, so I can see someone said compounding medication is double the price of a tablet. And I'm actually might be even more expensive than that. I guess what it comes down to is, some people that come off these drugs will take their lives from withdrawal effects. Some people will be incapacitated by withdrawal effects. Other people who won't be able to come off the drugs will experience obesity and changes in functioning. So to me, cost of an extra $20 or $30 a month is vastly outweighed by the savings to the health system caused by reducing side effects and by reducing some of the horrific things that happen to people in withdrawal. So to me, the economic case is clear. I guess it just takes time for that to filter out into the system to recognise things. One of the major barriers to this is because most clinicians haven't been taught to recognise withdrawal effects. When these things happen, they write down as their diagnosis, a new onset mental health condition or a physical health condition. So they're not aware of the costs being accrued to it because of withdrawal. And so I think the first step is awareness, that people actually know that this is what's the cause of so much trouble when people try to stop the drugs. I think it will naturally come out of that spending an extra few dollars on liquids or medication makes sense. And I'll just say something about kind of this off-label options, because I can see there's comments, the ones that I normally get, which is it's too complicated. It's not what we're used to doing. I guess, and I agree with that. Look, it is complicated. It is more involved. Although we've all taken an aspirin and dissolved it in water, it's not completely beyond what we would normally do. If we decide we're not going to do that, then we're deciding that we prefer to have people stay on drugs they don't need rather than crush up a tablet. So I think pharmacists can be very helpful in this. They can support clinicians to do this. I think that if we can get across that barrier, it may be that certain guidelines need to be updated to encourage people, as they have been in the UK, because once you get across that barrier, a lot of people can stop medications that they no longer need, and the benefits can be great for patients and for the health system.
And Mark, I'm seeing a bit of a theme in some of the questions and commentary that we're having in the chat, which I think is a great idea. Clearly, the UK is more advanced in terms of the clinical guidance that has been released for prescribers. But have you seen in the UK sort of short communication summaries, etc., that can be provided in a way that family members, people who are experiencing psychotropic overuse, care workers can actually use just to get their head around it, but to also start the conversation with prescribing GPs to pretty much bring a more informed conversation into these deprescribing discussions?
Right. Actually, probably the best resources I've seen have been developed by Catherine Wallace, who's a GP professor at University of Queensland. It's just for antidepressants, but if you go to her website, her trial is the RELEASE trial. She's developed some handouts for patients and their families about the long-term risks of antidepressants and why to consider stopping them. Probably we should do the same thing for other psychiatric drugs. There is in the UK, there's some guidance on benzodiazepines, why to decide to continue to stop. that's available from NICE. But for other drugs, I'm not top of my head, I can't think of something, but it's a good thing to work on. That's a good point.
Yeah. And what we will do as a commitment to all of the attendees is we're going to get the resources from Catherine Wallace and the wonderful work that she's done in the release initiative, and we will include that in the link that will be sent out to everybody who's attended, along with the video recording, the presentation that Mark has provided, the YouTube videos that we weren't able to watch, but we want to make sure everybody's got access to it. Mark, I do want to, we've talked a lot about the challenges, and the challenges are absolutely there. They are significant, and they are systems levels challenges. So I don't want to diminish that in any way, but are you also seeing the opportunities as you're going around talking to people across Australia, talking to people in the UK, talking to people in the US? What are the opportunities that you are seeing?
I mean, yeah, so I guess I talked a lot about the barriers. I mean, so I guess, there's a huge need for clinicians to be able to help people stop their drugs. I'll just give it a quick example of that. So, I've been an academic now for a few years. I wrote a paper. So my first 15 papers were nothing to do with stopping the drugs. And in my first 15 papers, I received one email about my work telling me I was wrong about something, as academics do. Since I've been writing about how to safely stop antidepressants and other drugs, I received 22,000 emails mostly from patients from Australia, from the UK, around the world, asking me to help them stop their antidepressants. I now get about 10 to 15 emails a day from people. There's a huge desire out there for people to stop these drugs. The people that are writing to me, are probably not the patients that people are seeing out there in the audience, because they're sort of sending me emails. But what they're giving voice to is, the fact that people are finding these drugs in the long term to cause more harm than good in lots of cases. People who are in care homes or with learning disabilities probably can't articulate those issues. What we're saying is, the weight gain, the emotional numbing, the cognitive problems, are not being made up for by the mood property or that. Unfortunately, people with communication issues cannot communicate those ideas. When people come off their drugs, often it can be night and day. People that I encountered who are on several drugs or been on it long term have all sorts of physical and emotional issues that resolve when the drugs are stopped. So it's been very rewarding for work in my clinic and see people coming off their drugs. People say they've come back to life, they've developed interests again, they've lost weight. I think one of the most surprising things to me is that a lot of people that have come off antidepressants, for example, have said they feel less anxious and less depressed. And I think that speaks to this growing field looking at tardive dysphoria, where people can actually have worse symptoms in long-term use of the drugs. There's similar evidence for antipsychotics, that people who are on long-term antipsychotics can have worse functioning than people that are not on antipsychotics. So I think the opportunities are, if you can get across the barrier of using liquids or these funny off-label versions of drugs, a lot of people who don't need to be on these drugs for long periods can come off them. That can have huge health benefits, subjective benefits, probably cost savings for the system. You save money on drugs, you save money on side effects. So I think this is, I think we've been through the last 2 or 3 decades of huge overprescribing. There's been, a lot of drug advertising. There's been a tendency to use drugs to fix lots of different problems. And I think this is now balancing, where trying to find, what is a sensible use of these drugs. And I think scaling back overprescribing is a very big opportunity to improve the health of the body. So to me, it's a kind of exciting field. There are some barriers that need to be overcome, and if we can overcome them, I think we can really have an effect on people's well-being. So I find that, very motivating.
And Mark, I think what I'm hearing from you is a real recognition there's a place for psychotropic medications. They can be beneficial. They can support us in our broader goals in terms of improving health and well-being for patients, but it's about understanding exactly how they work, what we can expect, and being really well-informed consumers and actually having great conversations in the room when the decisions are being made about, first of all, prescribing in the first instance and deprescribing. I am conscious that the people who have registered for this webinar are multidisciplinary professionals across all sectors. And what I'm hearing from you is that they all have a role to play in being able to advocate for patients for safe medication use and psychotropic medication use, but also for safe deprescribing. And what we're wanting to do via this forum is to give you the best information to be able to make informed decisions, to be able to advocate, and to be very realistic about what we are seeing and understanding what we are seeing when the patient is not able to tell us directly.
Yeah, I agree. So I think you're right. I think psychotropics have a role to play. I think sometimes, if someone's going to hurt themselves, if they're a danger to others, there are reasons to use psychotropics to control people's behavior. I guess what I'm trying to say is what might be useful in the short term may not play out in the long term. So it's always good to review these things. And I agree that everybody in a team has a role here. People that are seeing the patients more often, nursing staff, have greater insight into their changes in behavior. So I think that everyone can sort of feedback and play a role in spotting withdrawal effects and in advocating for rational use of medication.
Absolutely. Mark, thank you so much. Of all of the thousands of people who find their way into your inbox every day, I am so glad that I was one of them and that you were able to respond to my request with such generosity. You can see from the incredible questions that we've had, the number of registrations that we've had, the number of people who undoubtedly will also be finding their way into your inbox will be exponentially increasing because of the huge commitment to reducing and eliminating the overuse of psychotropic medications and chemical restraints in Australia. We really thank you for your time, Mark. We will be making sure everybody has access to this, to your wonderful presentation, the recording from today. We will send out the link to doctors and prescribers to make sure they have access to the Deprescribing Guidelines. If you don't get the link, go on any great bookstore and get your own copy. It's incredibly accessible content, and all of it to help us to be able to continue to advocate, to hold people's human rights at the front and center of the work that we do every day. Thank you everybody for sharing with us your time. This has been your own time, and you've been so generous in being able to join with us, and we can hope to continue this conversation with Mark and with the sector as we proceed. Thank you, everyone.
Thanks, Trent.